All right, so it is 3 o'clock, so I look at my watch. So we will get started. So this is billed as a Q&A, but Dr. Graham's going to take a couple minutes off the top to talk about something, and then we will get to questions. We have plenty of time, 30 minutes. So just to introduce him, for those of you who are not aware, he is one of the few dual MD DDS holders, so a medical and orthodontic doctor, a U.S. patent holder, a co-author of several textbooks, and of course a contributing editor to JCO. He runs our hot seat feature. So thanks to Dr. Graham for getting in the hot seat himself today. And why don't you go ahead and get started?
Well, Phil, thank you very much. I appreciate that, and I appreciate the opportunity to spend a few minutes with those who are and those who are not current subscribers to the Journal of Clinical Orthodontics. I watched with great enthusiasm Bob Keim's sort of introduction to the Journal of Clinical Orthodontics. He did a really good job, and for those of you that are watching this now or later, you can find that on our Facebook page, the JCO Facebook page, also on YouTube, on the YouTube channel as well. I would highly recommend watching that, and the reason that I say it is I've always been a great I would just say a history buff of the things that I'm involved in. I've mentioned this previously when I've lectured before. I did my oral surgery training at Parkland Memorial Hospital in Dallas, Texas, which is where they took President Kennedy when he was assassinated. And I had the fortune, great fortune, of operating with two of the surgeons that were actually in the room at the time. One of them was the one that was resuscitating the president actively. He ended up becoming a vascular surgeon and didn't talk much about it, but I have a whole presentation on Trauma Room 1 because I love the history, and I love the history of orthodontics. And that made me start to reflect on the things that Dr. Keim was talking about as he introduced sort of the fundamentals of what is the Journal of Clinical Orthodontics. It's important to me right now in the face of the most recent AJODO that came out, because in that Dr. Behrens introduces the AJODO Clinical Companion. Kudos to the AJODO for making an effort to allow more authors published. It's a very hard task to do when you have such a worldwide scientific journal. You get more and more and more submissions, and of course it's always heavily relied on the submissions of either full-time academics or those that are doing scientific work. And so I found it interesting, though. Dr. Behrens, in his, if you'll indulge me, just talked about what their clinical companion is going to do, and it's important to listen to this because it's striking. The parallel illustrated throughout this publication will include figures, photos, and illustrations. Coverage includes practice management, diagnostic procedures and treatment planning, imaging techniques, orthodontic materials, strategies that include aligners and implants, surgery, TMJ disorders, craniofacial treatment, sleep apnea, among other things. And then he introduces a very fine orthodontist, Jae-Hyun Park, who will be the editor. This is only going to be online, as far as I understand, every other month. But Dr. Park mentions in detailing what they expect to have as a part of this online clinical companion, that's one of the things that he mentions is that there will be a report on products and procedures to help clinicians by providing new information about products and treatments. Well, kudos to them, but I have to say, with all sincerity, that journal already exists. The peer-reviewed journal since 1967, started by Dr. Gottlieb, initially in 1964, and then ended up in September publishing the first Journal of Practical Orthodontics in 1967. That was their primary mission, to have a peer-reviewed journal that was exclusively focused on the clinician practicing orthodontics in their office. I didn't realize at the time, but I just kind of, it came into sharp focus today as I was watching Dr. Keim's presentation, that I have sort of a tie to the editors of this journal, or at least two of them, on a very molecular level, and that tie is the land of our birth. Both Dr. Larry White, who I respect immensely, know him and love him, and also Dr. Keim are New Mexicans. Both of them lived and practiced in New Mexico, and I was born and raised in Albuquerque, New Mexico. That's a strong bond, because there are hardly any individuals that you'll ever meet that live in New Mexico. In fact, a fair number of individuals don't even know that it's one of the 50 United States. They will say, oh, New Mexico, as though it's sort of a territory of Mexico, and you have to let them know that it's actually a state. So I feel a tie to these great clinicians, these great editors. And I really appreciated the firsts that Dr. Keim mentioned. Probably one that's near and dear to me is the Tom Creekmore article in 1983, which was the first introduction in the world, as far as I know, to orthodontists about skeletal anchorage, something that he had been doing in his own practice, and then he published it there. It was quite a first. And one of the things that I personally found to be a first that Dr. Keim didn't mention, but I had the great honor of having a relationship with this fine clinician, Dr. Len Fishman, from the University of Rochester, Eastman Dental Center, which is where I trained. And just as a sideline, Len Fishman's son, John Fishman, was the drummer for the band Fish, which some individuals may have heard of in the past. Dr. Fishman has been highlighted in the journal before for being a great artist. He's a sculptor. But the other thing that he did, which was a first, and I thought it was great, because after watching Dr. Vince Kokich Jr.'s presentation today, one of the doctor presentations Dr. Kokich gave. At the end, he was talking about how to communicate with patients visually. He was kind of highlighting a great program that you can purchase for your iPad known as Procreate, which is an artistic using the Apple Pencil, and he talked about how he does that with his patients. Well, that made me think about one of the articles in 1976 that Dr. Fishman published in the Journal of Clinical Orthodontics, and I encourage any who are current subscribers to get online and look it up, because it is entertaining at this point. But he actually published an article that was describing using an overhead projector next to his patient chairs, using transparencies of their cephalometric tracing to not only help him as he was treating the patient, but to visually help the patient understand what was going on. Yeah. This was long before any practice management software ever existed. And Dr. Fishman was talking about using visual adjuncts to help him as a clinician. And that was one of the things that the JCO brought to readers across the country. He actually has photographs in that article, if the readers want to look it up, of one of his transparencies. Amazing to even talk about that today, given what we have. But I mean, you talk about cutting edge. The JCO has always been that way, right? And one of the things, go ahead.
For sure. That's always been, and it's interesting. I just want to interject, just for anyone who's coming in, that for questions, we're going to put those in the chat, because I think I didn't say this at the top. So if you have a question for Dr. Graham, stick it in the chat, and that's where we will see it, because we're not going to deal with unmuting and muting and all that stuff. But yeah, we've been, the cutting edge has been, I mean, that's a regular feature of JCO, of course, but that's where we've been. It was fun to do when we did our 50th anniversary issue, which I believe you were a part of. Leading up to that, we also did 50 years to our 50th on Facebook, and we had kind of spotlighted an article or two out of every year. And I put that together and went back and going through all those old articles. It's fun to look at the old technology article, but I mean, we were writing about computers in the mid 70s.
That's right.
Yeah. So,
and there was no journal doing that, as far as I know. I mean, you would know that better than I would, Phil, but I don't think there was any journal, at least in the orthodontic sphere, that was even touching those topics.
Yeah.
And so it's been sort of the hallmark of our journal. And there have been, there was a great presentation that was, Neil gave a great presentation today about some of the clinical pearls. This has always been the lifeblood of the journal, and I feel very fortunate to be a contributing editor. I was asked to be a contributing editor well over a decade ago after I had submitted and published 2 different articles in the JCO, and I'm grateful that Dr. Keim took a moment today to mention to everybody that this is indeed a peer-reviewed medical journal. This is not a industry rag, so to speak, that you throw away journal that people talk about. This is a medical journal that is peer-reviewed and goes through a rigorous process. And Dr. Keim talked about the fact that there are so many that do not get published, unfortunately, but that's just the nature of the journal. So I'm grateful to be a part of that. I'm grateful that the AJODO feels that this will be a good addition, and maybe it surely will. But I feel strongly that it's important to note that we've had that journal since 1967 without fail every month. Just the best kinds of applicable real-world orthodontic practices, procedures, products, practice management, top to bottom, without a single rat science article on, crevicular chemistry in the PDL.
Yeah, Gene, Dr. Gottlieb had a few founding principles, and so Dr. Keim likes to quote them sometimes, and one of them was about the rat studies. So,
yeah. That's a shout out to Dr. Gottlieb. Yeah.
Yes, for sure. So if you have a question for Dr. Graham, if you're just coming in now, go ahead and put it in the chat, and that's where we'll read them off of. Just to start with, I had mentioned at the top you have the dual MD, and I remember a year ago, well, it was a little over a year ago, but we were doing a lot of COVID coverage.
Yeah. And
one of them was in part from you, though there are many contributing authors to it and a lot of signatories to it, an editor's corner last May. And you can stop me if I'm mischaracterizing, but I think the central premise of it was sort of like, we got this, right? Orthodontics
Absolutely.
Are well-trained in infection prevention. With some tweaks for COVID specifically, we can handle this. So now here we are, a year later. How are you feeling about where we are in terms of infection, how we've done?
I think we had it. I think exactly what you said, Phil. We felt at the time, listen, this is no different than what we should be doing every single day anyway when we're practicing with universal infection precautions. And our message, in a fury of panic-inducing headlines and fear-mongering from every corner of the globe, our message was simply, look, we've got this. And unfortunately for clinicians, at least specifically in the United States, we were mandated by the American Dental Association to quit practicing, which was the side effect that was probably the most impactful, negative, and I don't want to be dramatic, but deadly, of the entire effort, because it hurt a lot of practitioners. However, all of that being said, here we are over a year later, and I'm very proud of our profession because we handled it with grace. We did a great job. We see so many patients on a daily basis that we were far more exposed, in my opinion, than general dentists or any clinical physician because of just the frank number of individuals in our offices, not just patients, but every individual that brings those patients to our practice. I mean, on average, practice has hundreds of people in and out of their doors, whether they're a patient or not, every single day. And we really did a great job. We had some very sad losses. We did lose a couple of orthodontists, but when you look at the numbers of people that practice and the numbers of people that were getting infected with the virus, not necessarily getting sick, but getting infected, it was something that we really had to take seriously, and we did, and I'm grateful that the journal took it seriously and that we were able to publish that. And also kudos to you, Phil, and also those at the journal that worked very hard to keep our readers and also non-readers informed during those relatively scary, for many people, scary times. People didn't have patients walking in their doors because we were shut down. And then on top of that, we had the infectious disease, specter that was sort of hovering over all of this. It was a time uncharted in our history. And the JCO worked very hard and felt it a duty. And they did it well, including you and Dr. Keim and everybody, to just stay connected more than anything else, just to feel like you're not isolated as a practitioner, that we're all in this together, that we're all thinking the same thoughts, experiencing the same fears and worries, and ultimately sharing in each other's victories. So I'm glad you brought that up.
Yeah, well, it's interesting because it does dovetail into something else that, I think a lot of people have talked about back then, as a sort of a question of permanency versus temporariness. And I know, so you have an office that's very open, and it's
right. You can see it behind me. This is my office. Yeah, I don't even have a wall that separates my lobby from I'm essentially standing in the lobby, and you can see that you can touch one of our patients in the clinic if you wanted to from the lobby. Right, very open.
Yeah, and so I think. I don't believe you did anything super drastic to your office layout to try to, I know some people did,
right?
But you didn't, and
no.
I think you found that it was fine, right?
It was fine. I mean, everybody obviously wore masks, and the one thing that we did do is we reduced our patient volume, the traffic through our office, fairly significantly. You can see the chairs behind me. Normally, all 5 of those chairs plus an overflow chair over there is filled all day long. And so what we ended up doing was staggering so that each patient had an operatory chair separating them from the other patient. But, we had no, at least as far as I am aware, we had no incidents of any kind of cross-contamination. I had two staff members that ended up testing positive for COVID. They obviously stayed away for the required amount of time, did all the appropriate testing, and we informed our patients of that. And at least to this day, I know of no incidents that I can point to of any kind of contamination. We did just fine, even in such an open bay scenario as you see behind me.
And one question here, it's a little more current, I guess, although maybe not now, but so how did you, as the boss also of everybody, how did you handle the vaccine issue with staff?
It's a great question, because that borders on personal / political / paranoia, the 3 Ps, I guess. And so it's one of those very polarizing, very divisive topics, unlike anything else that we've had as far as immunizations go in the history of U.S. medicine. So basically, and as far as I know, every staff member in my office has been vaccinated, including myself. And I say as far as I know, because all I can do as a boss is recommend that they be vaccinated, but I will not fire somebody because they refuse to be vaccinated. We all follow the same precautions, vaccinated or not, simply because right now the CDC's recommendations are such that those individuals who are vaccinated don't need to wear masks outside and don't need to follow social distancing anymore, but for those that are in healthcare settings. And so currently the CDC still recommends that if you're in a healthcare setting, you still wear a mask and try to do social distancing, those kinds of things. So whether or not they're immunized is a personal choice for them. You wouldn't know one way or the other based upon how we use PPE. We use the same PPE that we always did, and which, by the way, except for maybe the first couple of weeks, but by the way, is not drastic. I mean, we wear masks and we glove up, but we're not wearing shields. We don't have giant suction units sucking out all of the air and pumping it outside or anything like that. And the more we learn about the virus, the more that we know that indeed it's not very surface borne. It doesn't live very well on surfaces, certainly doesn't live under ultraviolet light very well. There's a lot of things that we're learning, by way of the science that's coming out. So it's a good question, but it's a tricky one. It's one of those things that borders on, personal invasion of privacy. When you ask, even as an employer, there are some states now that have passed legislation stating that their employers cannot fire them if they find out that against their will or against their recommendation, staff members refuse to be vaccinated. Now, not every state's doing that, but you can see how polarizing it is, and it's very it hits a nerve with everybody. So you have to kind of, as a boss, have to be very cautious, yet let everybody know what you're doing personally, and hopefully that example will permeate the staff.
Yeah. This is a little bit of a topic switch, but anyone who wants any other questions about COVID, you can stick them in the chat. But we don't need to spend the whole time on it. So the hot seat, there was a hot seat on accelerated orthodontics. It was several years ago. I don't have the exact date offhand here.
Yeah.
But it was interesting that when we did the last diagnosis and treatment study, which was now 2 years ago, there was no growth shown in accelerated orthodontic use from 6 years. We do the diagnosis and treatment study every 6 years. So over those 6 years, the usage had basically stayed flat. It hadn't grown, and that was surprising to us. We thought it was going to grow. I know you're a proponent of it. So what are your thoughts on why it hasn't taken off? Like, we've seen aligners explode.
Oh, so, for sure.
What's holding it back, do you think?
I think probably, Phil, what a great question. I think there are two factors. The first one is that the science really is not tremendously overwhelming when it comes to accelerated orthodontics using non-invasive techniques, meaning either vibratory appliances or pulsed light appliances or combinations therein. There are studies, but like most studies, if you look at it with sort of a jaundiced eye, you get to the bottom of who financed those studies, those kinds of things. The one thing that we do know with hard science that does accelerate orthodontic tooth movement is inducing bone trauma. So if you're using we call it the MOPS technique or the microosteoperforations, there's no question that absolutely increases the rate at which teeth will move under orthodontic forces. And it's well documented. But the problem with that is, Phil, that there are the vast majority of orthodontists, and I know this having been out in the world for a long time trying to convince orthodontists they can place TADs and things like that, there's a real hesitancy to adopt those kinds of methodologies in a standard busy orthodontic practice, whether it's because they don't want to deal with anesthesia, or maybe they don't like blood, and that's possibly why they went into orthodontics instead of another discipline in dentistry. I don't know, but I think that's probably why there isn't this just huge embracing of those procedures, because the ones that are not invasive are still just not overwhelmingly proven to make a significant difference in a patient's course of treatment. Now, you could argue that all day long, but I think that's probably why. And that's a really, really good question, because you think by now, that's the one thing every patient has in common. They want this to be over with. And if we can provide that to them, you better believe we're going to try.
So are you still using, I can't remember from that hot seat what you were using at the time, but are you still using accelerated in your practice? So really not as much as I used to. And I think part of the reason is that just using techniques that I have learned from other orthodontists and developed myself over time, I've become pretty efficient with my tooth movement. Now, there are occasions where there is a case that is very complex, and I get a lot of complex cases. Not that I love that. I don't. I used to. I'm not so much anymore, but that's okay. They're challenging and multidisciplinary, but there are some very complex cases where the patient absolutely, for whatever reason, must have treatment shorter than you are anticipating it would take. And, you tell the patient, look, this is difficult. We're talking 24 months of treatment here. And the patient's saying, this has to be done in 8 months.
I've got to do this, right? So those are cases that are compelling enough for me that I will go ahead and do it. But other than that, I haven't really had a lot of pressure from patients because I think that the treatment times are reasonable. At least in my practice, they're reasonable. At least I feel they are anyway. Yeah, there are always outliers, but so I wouldn't say that I don't use them on a daily basis. That's for sure. But if I need to, I will.
Yeah. And just to reiterate for people coming in the middle, if you have a question for Dr. Graham, just stick it in the chat section and we will look at it there. We're not unmuting or anything like that. It just gets too complicated. So I see, since I mentioned aligners, someone asked about aligners. We just did an issue on complex treatment with clear aligners. I'm sorry, right. I'm kind of paraphrasing the question around a little bit because I know we just did this issue. What are your thoughts on that, on going into the really hard complex cases like the one you just mentioned, and pushing the kind of the frontier with clear aligners and treating them?
Well, I do it. Now there are cases where it's obvious to me that plastic isn't going to do what I need to have done, but that does not necessarily, for example, let's say a horizontally impacted tooth. Plastic can't do that, especially if it has to be exposed and bonded. And, it can, but at the expense of what? The expense of a lot of trays, a lot of time. However, I still want most of my patients to be in aligner therapy. I would say 85% of my practice is aligner therapy. And so in those patients, then we just do a hybrid. And I think that hybrid treatment is going to become very common, meaning that we do the heavy lifting, so to speak, with traditional brackets and wires, things that we know can be done. We can predict it. We know probably how much time it's going to take. And then once all of that heavy lifting is done, which doesn't necessarily mean the majority of the case time, then we switch to aligners. Patients are so grateful that you're at least attempting to make their course of treatment or see it from their point of view. I think that they're starting to realize that the really successful orthodontists out there are ones that see their patients as customers as well, and that you have to think in terms of a customer. And what would differentiate me going to one over another? Well, the practitioner that seems to really anticipate the concerns that I'm going to have and address them right off the bat are the ones that end up being so busy that, you can't get an appointment with them for months and months. So I think that hybrid treatment definitely is the way to tackle really tough cases. And just because it's hard doesn't mean that you can't do aligners at all. In fact, it's probably even better for the health of the gums and the teeth and all of that if you can do a hybrid treatment for very difficult cases.
Right. And what about seeing here? Are you in-house printing if you're doing that many aligners?
I do both. Yeah, it's kind of a hybrid. I do both. I am a heavy Invisalign provider. I'm one of the top in my state, but there are many cases where I don't want to spend that kind of money for a patient that doesn't need more than, say, 10, 15 trays or whatever, or I'm doing detailing work at the end of treatment where I just want to take the braces off and do detailing. So I have 2 printers in my office, and I do workups myself with software I don't get paid by them, so I'll tell you it's ULab's software that I like very much, and it allows me, I can turn around a case the same day. If I have a patient that comes in and I need to do something and they're leaving that afternoon, I can bump them to the top of our queue, so to speak, and I can do the case in 15 minutes and have it on the printer and ready to go, and they can pick it up the same day. And I think that the ability for orthodontists to provide same-day aligners is going to be something that is game-changing for orthodontists across the globe, really, because patients really want that, and it's not a hard thing. We're not sacrificing anything anymore. Even if there are orthodontists that will print the first 3 trays of a long case in their office so the patient can get going and get started, and then the rest can be fabricated off-site or third-party or whatever. There's so many ways to break it down and look at it in a way that's helpful for the flow of the office that I think that it's an inevitability that almost every practice ultimately is going to have 3D printing technology in their office, because it isn't just a novelty. It is really providing things that patients demand. So it's exciting and it's fun.
And what changes did you have to make, if any, to your practice flow to accommodate the in-house printing? Or are you treating it as basically just like the other ones, or what are you doing that's different for the in-house people?
The biggest change is not anything that has to do with the patients. It has to do with the doctor. In order to keep up with all of your cases, you have to be very disciplined and figure out a method by which you are able to, not only if you're doing Invisalign as well, do all of your clin checks, but then you've got this stack of 57 patients that are in your queue that you have to do workups on and, take care of all of that. So really what it boils down to, the changes are doctor timing changes. A lot of doctors will have a column almost like just a regular chair in their office and treat it like a patient, and a staff member will pull up a case that needs to be done by the orthodontist, and they'll call them over just like they would be seeing a patient and say, right now you need to do this case before you see that next patient sitting there. This is your patient. You got it. That's one way of doing it. It's not how I do it, but it's one way of doing it. So those are the big changes. From a patient facing standpoint, there aren't any that they notice.
And do you have someone's asking about printers themselves? I guess I'm assuming you're also not paid by your company.
Correct. I'm not. Right. So, no. I pay a lot of money for those.
But
yeah, I'm not paid
for your printing.
I have two printers right now. I have a Sprint Ray Pro. I initially had a Form 2 by Formlabs that was a great printer. It was a good price point, like $3,000, something of that nature, several years ago, but it was not fast. So the Sprint Ray then became a fast printer. Well, Formlabs came out with their Form 3 printer, which is blazing fast and has aspects to it that I prefer over some of just the ways that the Sprint Ray Pro does the print. I think the Formlabs is a little bit better, a little bit superior to that. So those are the two that I have. They're usually both running constantly in my practice. On both of those, we can print 40 models at a time, essentially in about an hour and a half each. So you can really pump a lot through. I have a very good friend, Jeff Pascal, who's got a whole array of printers along a wall in his office. He's got quite a production, and there are quite a few orthodontists out there that do that have essentially become manufacturers. And now that we are able to print braces, which is it's being advertised at this conference, attachments, braces, etc. The role of in-office manufacturing is only going to explode over time. It's going to get easier, it's going to get cheaper, and it's going to get far greater in its breadth of application.
Right. I think we're pretty much out of time. So I did want to ask you this. This was my question, but it's something we actually touched on at our own editorial board meeting recently, and I just think it is on the top of a lot of people's minds with aligners. So we have the DIY, growing and growing, and of course, as always, dentists doing aligner therapy themselves and not referring it to orthodontists. How do orthodontists, I don't know if fight back is the right way to put it, but how do they succeed in this market where it seems like more and more companies are trying to elbow them out of the process?
Yeah, that's a great question. And listen, I think it all boils down, Phil, to mindset. I think that if the orthodontist has an abundant mindset and realizes that this is actually a benefit for orthodontists, I mean, there are more patients now, adult patients, that understand that they can have orthodontic treatment without braces at any age because of the vast marketing campaigns of all of these do-it-yourself, essentially, type aligners, direct-to-consumer, all of that. I've certainly seen an uptick. I mean, I practice 3 days a week, and I have, you can't get a consultation appointment with me until almost the end of October, and almost all of those patients are asking for clear aligners. That was not the case 2 years ago, or even a year ago, but it is now, and I think that's a direct result of this push for getting in, as many companies as you can. I just see it as a benefit. I think it's wonderful. I and many orthodontists retreat, sadly, a lot of those cases, but a lot of patients come in after having initially explored those and then come to their own conclusion that, it's probably better that my treatment is doctor directed and not necessarily, even though those companies will claim that theirs are, but there's certainly doctors from many, many miles away, and who knows how many times they're actually making touch points with those patients. So I look at it as a win for orthodontists. And I think if you keep that attitude, that abundant attitude as an orthodontist, I'm just a big believer in sort of a karma situation. If you feel that way, it's going to happen just by intention. It will happen. And I think it's great.
Right. Well, I think we'll stop there. Thanks again, Dr. Graham, for taking the time out for this.